All right, hello everyone. My name is Sana Altamimi and I will be presenting on perilymphatic fistula for HSL 817, the anatomy and physiology of the auditory and vestibular systems. Going over the outline for this presentation, I will start with the definition and etiology of perilymphatic fistula. After that, I will discuss associated clinical findings such as symptoms and other clinical presentations. Then we will learn some of the ways that perilymphatic fistula is diagnosed, and finally, how we can treat and manage this condition. So looking at these terms separately, we can see that perilymph is defined as the fluid between the membranous and bony labyrinth of the ear. And then fistula is essentially defined as an abnormal passage that leads from one hollow organ or part of the body to another. So putting that together, we can say that a perilymphatic fistula, or PLF, is an abnormal connection, like a tear or defect in one or both of the membranes, that is the oval window or the round window, that separates the air-filled middle ear and the fluid-filled perilymphatic space of the inner ear. This small opening allows perilymph fluid to leak into the middle ear. When perilymph fluid is lost, it alters the balance between perilymph and endolymph within the membranous labyrinth, and depending on the location of the tear, it can cause air bubbles to expand and affect the organ of Corti responsible for our hearing. So let's take a closer look. So we have an oval window tear here, and we can see that it starts as a small air bubble in the scala vestibuli, and then it expands and pushes on Reisner's membrane. However, a round window tear would start off in scala tympani with a small air bubble, expanding and then eventually pushing on basilar membrane. So now that we understand what this is, we can ask, how does this happen and what causes a tear in the first place? Well, perilymphatic fistulas can be categorized in 4 ways. Category 1 is linked to trauma, middle and inner ear diseases, middle and or inner ear surgeries as well. So an example of trauma would be a TM perforation or maybe a concussion. In terms of diseases, it could be a cholesteatoma, which could erode the bone and cause a leak, or maybe a surgery like for otosclerosis, a stapedectomy. So if the prosthesis becomes displaced, there could also be a leak. And for category 2 is linked to barotrauma caused by antecedent events of external origin. That examples of category 2 includes flying, skydiving, or scuba diving. Category 3 is also linked to barotrauma, but caused by antecedent events of internal origin as opposed to external. So category 3 is internal. And some examples include any form of intracranial pressure like sneezing or heavy lifting, anything with straining. Category 4 is essentially idiopathic. There is no known cause. However, that is very controversial among providers. Some believe that there are cases of idiopathic perilymphatic fistulas, but others believe it's just another pathology known as period canal dehiscence syndrome, where the bone of one of the semicircular canals is eroded, leading to a third window for perilymph to leak. So before I go over the clinical presentation in detail, here's a video of a man named Jonathan that acquired perilymphatic fistula after a skiing accident, which actually represented his 7th concussion. So let's see what kind of symptoms he is experiencing.
So when I cough or sneeze, I usually see stars. And it hurts my head. I get dizzy. I have to hold on for 30 seconds to a minute before I can move on and do something else. um, when I say I don't pop my hairs, housework or yard work, anytime I do anything, even mildly strenuous, bend down, pick something up, on the dishwasher, it hurts very bad. The pain in my head skyrockets and I get dizzy.
Right, after watching this video, we can see that patients may experience a variety of symptoms such as dizziness, vertigo, nausea and vomiting, headache, memory loss, sudden or progressive hearing loss, tinnitus, and the feeling of fullness in the ear. So these symptoms may vary in severity from mild to incapacitating. In general, perilymphatic fistulas are a rare occurrence that happens about one every 100,000 adults. And below, I ask, what other conditions do these symptoms resemble? If you think about it a little bit, you might remember a condition known as Meniere's disease. A lot of these symptoms overlap, but the main difference is that perilymphatic fistula typically presents after some traumatic event. Other conditions could be a tumor or vestibular migraines, but in the next slide, we will go over the diagnostic measures to ensure an accurate diagnosis. All right, as of yet, there is no definitive diagnostic criteria. However, there are a series of tests that can be used to diagnose this condition. I'd like to note that because there is no universal diagnostic criteria, I've compiled a list of many diagnostic measures, starting from the most reliable to the least reliable. So starting with CT scan, particularly the high-resolution coronal or sagittal views are the most reliable method for diagnosing perilymphatic fistulas, and it can indicate if urgent surgical intervention is needed. So you can see in this photo a coronal CT scan of the temporal bone showing an air bubble in the second cochlear turn, just where that red arrow is. So for the MRI scan, can rule out any other factors that may be causing these symptoms, such as a tumor. But the combination of CT and MRI was reported to diagnose almost 100% of the cases. Another way to measure, another way to test for perilymphatic fistulas is through audiological assessments, which can include a hearing test that typically shows a unilateral sensory neural hearing loss. And if you remember the air bubbles I showed in the picture a few slides ago, depending on where the air bubble is and where it's the organ of Cordy's being compressed, could determine what kind of hearing loss that is. So there isn't much research about that, but essentially we will see a unilateral sensory neural hearing loss unless both sides are affected, then we know there's a bilateral sensory neural hearing loss. And as part of the basic test battery, audiologists may choose to test middle ear compliance in a tympanometry test. If a patient reports dizziness during the test, the audiologist could suspect a fistula. Another test called electrocochleography is used to look at the activity in the inner ear as it responds to sounds. This helps determine if there's an abnormal amount of fluid pressure inside of the inner ear. The next test is a balance test called video nystagmography, or VNG. And that can help determine if a patient is experiencing dizziness that's caused by an abnormality within the vestibular system. So after this procedure, the healthcare provider may conduct a fistula test. If nystagmus is presented when a negative pressure is applied, then we can suspect a fistula. However, the sensitivity of this test ranges from 0 to 77%. And last, we have exploratory tympanotomy, excuse me, otherwise known as intraoperative observation. This used to be the gold standard. However, this test is subjective as there is no criteria for what constitutes a perilymphatic leak. Since the improvement in resolution of various imaging studies has improved, exploratory tympanotomy is not performed often. All right, there's a spectrum of treatment options for perilymphatic fistulas that range from conservative to surgical. Generally, tears of the membrane can heal without intervention, so healthcare professionals recommend bed rest, keeping the head elevated, and to avoid any kind of heavy lifting or straining for 1 to 2 weeks. However, if symptoms do not improve or are really severe from the beginning, other methods like a blood patch procedure or surgical treatment should be considered. The blood patch the blood patch procedure is a new outpatient procedure that can be completed within 30 to 60 minutes in the office. It involves injecting the patient's blood into the middle ear, which in turn patches the defective or teared membrane. The next line of treatment, if this doesn't work, would be surgical intervention, where the eardrum is lifted and a soft tissue graft is placed around the base of the stapes and the round window. Usually, patients can go home the same day, or they may be kept overnight to restrict activity. And I wanted to show this comparison of the audiogram before the blood patch procedure. So on the left, right here, we can see there's this trough-like sensory neural hearing loss. And this is a patient that presented with this sudden hearing loss after blowing her nose, but showed improvement of hearing in the normal range 1 week after a blood patch procedure. All right, and surgery is effective and can relieve vestibular symptoms in 80 to 95% of the patients. However, only 20 to 49% of patients will experience improvement in their hearing. So it's actually really important for these individuals to get repeated audiological evaluations to monitor their hearing. Because blood patch procedure is fairly new, there is not much data about whether or not patients experience relief from their symptoms. However, the pre and post imaging studies, as well as the audiograms that I showed in the previous slide, look promising. So to conclude this presentation, we will watch what happens after Jonathan receives the surgery to repair the perilymphatic fistula.
36-year-old male presenting with bilateral fistulas. The right ear was repaired yesterday. Today, I no longer have light sensitivity, no longer have memory loss, no longer have confusion in my cognitive processes or stammering or slurred speech. I no longer see double vision.
So we can see there's a major improvement in how just even Jonathan is presenting himself, something that was so hurtful for his everyday life and his quality of life is now finally so much better after the procedure. So very happy for him. And with on that note, here are my resources. I look forward to answering your questions. Thank you so much.